Hello, everybody, and welcome to the Modern Medicine Podcast. I am your host, Dr. Dennis Tian, MD, MPH of Beth Israel Lahey Performance Network, coming to you with our monthly episode of the Modern Medicine Podcast. And I am so excited for our episode tonight because we have so much great stuff to talk about, and we have a great guest with us, Producer Dave, joining me as always. How are you doing, Producer Dave?
Not too bad. I don't want to jump the gun. I'm very excited for the Boston Sports Minute later, but we have terrific guests, so I don't want to delay that. But
Yes.
Things are nice in New England now.
Things are looking up here in New England. The guest tonight is Dr. Smita Das, who is a clinical associate professor of psychiatry and behavioral sciences from Stanford, joining us to discuss really her specialty is addiction medicine, addiction psychiatry, and we're going to talk about marijuana and the health effects of marijuana, because this is a super hot and important topic in medicine right now. And it is a topic where there is just so much misinformation and misunderstanding. And we talk a lot about following the science. And I think that's our obligation as professionals. We have to follow the science. And I think in this area we're failing. So I asked Dr. Das to join us after reading another interview she did on another podcast as part of an American Medical Association continuing education credit that I had come across. And she was gracious enough to do so. So we'll welcome her to the podcast now. Welcome, Dr. Smita Das.
Thank you. Thank you so much for having me today.
Awesome. And you are joining us from sunny California, Stanford.
Sunny California, yes, the San Francisco Bay Area.
It's been unseasonably cold here in New England the last week. It was nice up until then, but well, welcome. We're so happy to have you. I want to talk a little bit about your background and just to give the viewers and listeners a little understanding of what you do and who you are. You are board certified in psychiatry and addiction medicine and addiction psychiatry. Started with chemistry and statistics at Stanford, completed your master's in public health at Dartmouth College, and then an MD PhD in community health at the University of Illinois at Urbana-Champaign. So, and a psychiatry residency at Stanford, also serving as chief resident, followed by an addiction psychiatry fellowship at UCSF. So over 2 decades experience in healthcare quality research and addiction and clinical medicine. So we are just totally honored to have such an amazing guest join us on the podcast.
Thank you.
So I want to talk, we're going to talk about the health effects of marijuana, because this is as I said, it's a topic of importance right now. And I want to start by just this, which is when we talk about marijuana legalization, which is a trend that has really kind of swept our country over the last, decade plus. And I was an opponent of marijuana legalization for a lot of reasons when it was voted on in Massachusetts. And what I've seen over the last few years since it was passed is that it may be possible for us to have an effective legal marijuana system, but it hinges on an effective public health system. And I think whether marijuana is legal or illegal, where we are failing right now, at least in Massachusetts, is on getting an effective science-based public health messaging out there to the population. And that's what I want to kick it off with, what your thoughts are about that.
I agree. I spent many years, actually a decade, on the American Psychiatric Association's Council on Addiction Psychiatry, where we had a cannabis work group. And as you can imagine, over that decade, from 2013 to about 2023, there was a lot of change when it came to cannabis and legalization. And we would always say, we early on, I think physicians in general and medicine in general kind of missed the train in terms of the legalization. That train had already left the station, and we needed to do something. And so a lot of how I think about this is in terms of policy. Now that this is increasingly legal, every time I give a talk on cannabis for Grand Rounds, I have to update my map and update the number of states as it's increasingly legal. We need to have in place policy policies so that we are reducing harm, and also talking about the reality, and instead of this kind of misguided perception that this is a thing that is going to be helpful for all ailments and conditions, and unfortunately that's where we're at today.
Exactly. And you obviously are out in California, but if you drive down parts of Massachusetts, you will see billboards that routinely associate cannabis with health and wellness. And it's like, that is actually outright non-scientific. Now, there may be benefits, like this is something that needs to be studied, but there is also a lot of studies that show clear evidence of harm or potential harm. And it's really, I think, misleading to people to promote this as something that is healthy or promoting wellness without consequence, when actually we are getting more and more evidence piling up that both physically and mentally, and I know with you here, we're going to talk more about the mental neuropsychiatric side of it, mental health side of it, but there is more and more evidence piling up that's telling us that there actually is a lot to be concerned about.
Absolutely. And it's funny that you mentioned the billboards, because I've over the last few years have had to do a couple of talks at Harvard and at Brigham. And one of those talks, it was perfectly teed up as I drove from the airport, or had the rideshare take me from the airport to the hotel by the university. There were just so many billboards. So that I opened my talk with, let's talk about this, because it is not going away. It's increasing in prevalence in terms of how available and how many people are using, as well as the advertising and the messaging.
1,000% correct. So let's talk about some of those health effects, especially from a psychiatric and neuropsychiatric perspective, which is, of course, your domain of expertise. And I'm going to just start with an analogy that I use a lot on this podcast, which is like when we're trying to determine causality and how things relate to each other causally, it's really hard. And you know that because you're a PhD and an MPH. I know that because I'm an MPH. I don't know if the general public understands that always, but I liken it to a jigsaw puzzle, right? Every study is like a piece of the puzzle. And we put a piece of the puzzle down and we're getting a sense of what the picture really is. We might never fully know. But I think with cannabis, we're starting to see that some of those puzzle pieces are coming down. And I think one of the clear take-homes for me, and we'll get into this into the details of this in a minute, but is that cannabis is really bad for your brain, especially at high potency, and especially if you use it at a young age for a long time.
Yes, those are all true statements. The last one that I would add to that is using daily. So not good for the brain. And you're absolutely right. It is hard to determine that causality. Anything that has to do with the brain is always very difficult to study. Luckily, there are more and more, for example, imaging studies that are showing us more. But even if we put the imaging studies aside, because we have kind of this natural experiment of sorts going on in the US as there's legalization, we are seeing that we can make stronger and stronger associations with cannabis and mental health conditions. And this is actually, while I've mentioned the US, it's in Europe that there's really, really excellent data, because they monitor and track cannabis potency and usage and health impacts a lot more closely than we do here. So we know that cannabis while unfortunately individuals are using it sometimes to try to ease things like anxiety and depression, cannabis can actually worsen those conditions. There is a really strong association with suicidal behavior, especially in young people. And then, of course, as you mentioned, high potency cannabis is absolutely being increasingly linked to psychosis, onset of psychosis, and risk of psychosis.
Yeah, it's actually all super frightening, because I can't tell you how many times I have a patient come into my office. I have like maybe 1,500 patients. I have a practice with 1,500 primary care patients. And it is not uncommon for someone to come into my office and tell me they use cannabis for their anxiety or depression. And I tell them, that's like telling me you're eating cheeseburgers to control your heart disease. Because, there's actually a ton of literature that, as you know, that there's a real risk, that there is a causally harmful relationship between those two things. So can you talk a little bit about, about what we know about how cannabis affects things like anxiety and depression and other mental health conditions?
Yes, so there are some very clear signals, and then more strong associations between several of these conditions. So very clear signals with diagnoses like social anxiety disorder, and also a lot of strong associations when it comes to risk of anxiety, depression, and then mood disorders. Things like bipolar 1 and 2 are also at risk of being either mostly worsened by the use of cannabis. And then probably the most important one, and I think the one that I get asked to speak on kind of increasingly over time, it has to do with psychosis. So high potency cannabis is related to the increased risk of first episode psychosis. There was a really great Lancet study in 2019 that, again, uses that European data that shows that high potency daily use of high potency cannabis is associated with almost 5 times increase in the risk of developing a psychotic disorder compared to people who don't use. And so that's really significant. Again, while we can't say that this is, there is absolute causality here, that's a very strong signal that individuals should be concerned about.
Right. Well, the more and more data that piles up, the harder and harder it gets to explain with just confounding and all this other kind of ways people explain this data away. When you have so much data that's kind of piling up, and I correct me if I'm wrong. There was a study, wasn't there a study a few years ago that showed a causal relationship, implied a dose-response relationship between cannabis use and psychosis, and it was as little as like using a couple times a year had a slightly higher rate of psychosis, if I'm not mistaken.
I'm not 100% sure about the study that you're talking about, but I can see that being true in part because I will have patients that come to me for psychosis, but they have really just used cannabis infrequently. Again, they were probably the patient that I'm thinking of right now that I saw in clinic in the last couple of weeks was seeing me for psychosis and substance use disorders. But the issue was that he was going to parties where he was obtaining some really, really high potency cannabis, and if when his body as a non daily user was exposed to that, he ended up going through really disabling psychotic episodes that landed him in the hospital. And so it is not something to be taken. One has to take it very seriously.
Absolutely, and so many people that are vulnerable, right? And so many of these patients are vulnerable, and so many of them have mental health issues to begin with, and they turn to these substances because they're being told one message by the media and by the product placement in popular culture and by the billboards and by everything else. And then they don't really even realize or appreciate the potential devastating effects this is having on their illness.
Absolutely. I think that there is such an increase in the media and the messaging, and especially with social media and celebrities doing paid endorsements for this and that company. It is something that our patients are paying attention to, and they're not aware of the dangers. And I have so many people who come to me and say, I wanted a quote unquote natural remedy. And I have to remind them that the cannabis that they're getting at the dispensaries, this is not natural occurring cannabis. This is not, I always say, this isn't the cannabis of Woodstock in the 1960s
Right.
and 70s. This is a very different type of cannabis that we're talking about now.
Right. And there also appears to be a bit of a genetic susceptibility for the psychosis thing. And we don't fully understand that, but there are some people that are more or less genetically susceptible to developing psychosis from cannabis.
Yes, absolutely. And so in the studies that have been done, including in that 2019 Lancet study, there is always mention of individuals who have a genetic predisposition that when they use high potency regular cannabis, that there is a risk of unmasking and potentially triggering or bringing up earlier symptoms that they may not have realized. One really great point out of the study is that that psychosis and the onset of psychosis potentially could have been may have been averted if somebody hadn't been using the cannabis. And so that's something I think, as especially I'm thinking about family members and parents, people who have dealt with psychosis in their families or psychotic conditions. They may be thinking about, okay, how can I prevent my child from having to suffer in the way that my sister did or my uncle did, and so really kind of thinking about exposure to substances is important.
Yeah, 1,000%. It's so important for individuals that have that family history of, or personal history, certainly, but even a family history of psychosis to use extra caution when dealing with cannabis. I do have one more quick thing I want to run by about this before I move on to something else, which is that I think one of the reasons, if you look at the literature for cannabis, like I firmly believe that cannabis worsens things like anxiety, depression, and leads to other various neurocognitive and neuropsychiatric outcomes in an adverse way. But if you really look at the literature, it really is almost really strongest for psychosis. And I think as someone that has some training in epidemiology, and I'm curious what you have to say about this, one of the reasons for that is that it's really easy to measure psychosis. Like psychosis is binary. There's no ambiguity to it. You either had it or you didn't. So when we see psychosis jumping off the page as being like one of the most firmly causal things, I don't think that means that things like mental depression and anxiety are less caused by it. I just think a lot of it has to do with the fact that it's way harder to measure some of these other things.
That is absolutely true. Psychosis is, it's usually a binary yes or no.
Binary.
Did somebody have it?
Yeah.
And in depression, we do measure. We have kind of standardized tools that we use to screen as well as measure. They certainly are a lot more time consuming to complete than seeing somebody in the ER and saying, wow, this person is actually experiencing psychosis. That's very crystal clear. And then I will just add before we move on that I think there's two other points that have to do with kind of neuropsychiatry that we haven't discussed, is the increasing evidence about impact on memory and cognitive function, as well as, of course, as an addiction psychiatrist, my topic that I see a lot of people for, which is the development of cannabis use disorder. So the addiction to cannabis is increasing as well.
Yeah, a huge thing. I was going to get to some of the more neuropsychiatric stuff, because I think that's hugely important too, because like there is, as you alluded to, there is an increasing body of literature that shows that there are real adverse neuropsychiatric outcomes in terms of various forms of memory and other neuropsychiatric parameters that are being adversely affected by cannabis. And I mean, that is a frightening thing too, when you think about like some of the neuropsychiatric ways that this is affecting healthy brains or otherwise healthy brains.
Yes, and I think that a population that I have been talking about a lot more recently are older adults, and so individuals who are starting to be concerned about memory and cognition more, and are increasingly turning to cannabis again to treat a variety of conditions. Older adults as well as young people whose brains are still developing, where the cannabinoid receptors and especially the abundance of the cannabinoid receptors on areas of the brain that are important for memory, like the hippocampus, those are all affected by cannabis use, again, especially daily and high potency cannabis use.
What about structural and functional changes on MRI and functional MRI? Because actually studies have kind of been mixed on that if you look at them, but it seems like most of the studies, well-done studies that have used functional MRI have shown more positive findings, whereas some of the ones that use traditional MRI maybe have been a little bit more mixed bag. But would you comment on the structural and functional changes that we see in brains of people that are using cannabis regularly?
Yeah, you're absolutely right. So MRI studies haven't been totally consistent in terms of those findings. We probably need more data or need to rely on other modalities like functional MRI. Based on MRI studies, there's likely changes in the hippocampus, as I mentioned, as well as the amygdala, a place that's super important for processing of emotions and mood. And these in the early studies using MRI, the signals were most apparent in people who use heavily and people who used earlier in life. In fMRI, we are getting still, a a more clear picture, but still there needs to, I think, as any good paper would end, there needs to be more research. There needs to be more because we know that there's altered functional connectivity in places like the orbital frontal cortex. However, there is also evidence that in some individuals, especially young people who use cannabis, there may be a decrease, but then a kind of rebound increase in that connectivity, the brain kind of trying to make up for it. And I think time will tell kind of what that means, if that's sufficient to make up for that initial decreased connectivity, or if it's something that someone is going to be suffering from.
And I think that's one of the real questions that still remains since you brought it up. First of all, let's clarify. When we're talking young people, we're talking people not like in their teens. We're talking people into their late 20s, because the brain is still developing into the late 20s. So when we say that all these adverse effects seem to be more powerful and potentially more likely to be permanent, we're talking about people into their mid to late 20s.
Yes, absolutely. So, when I'm thinking about young people and any substance use, I am thinking, all the way teens, 12-year-old to 25. In fact, the American Academy of Addiction Psychiatry has put out, as part of this work, they put out sample legislation for states to use as cannabis was starting to become legalized. And the recommendation was to push the use age or the sale age to 18, but ideally 25, because of exactly that the brain is still developing until the age of 25. And so the impact of substance use is still very strong.
Do you think, we've grazed on this a few times, but do you think that the effects of cannabis on the brain are likely to be permanent, or do you think that it's possible that some of this might resolve? I mean, the literature seems to be pushing more towards permanence, I would say, but I'm curious what your thoughts are.
I think especially for, I keep saying this over and over again, the daily user and the user of high potency products, I have a suspicion that we're going to find over time that there are permanent changes. The data are still mixed. I'm hopeful for the ABCD study coming out of NIH or the data coming out of NIH to hopefully shed some light on this over time as they have followed young people throughout their lifespan.
And then one more thing I want to bring up about this, some of the health effects is like, yes, we're seeing on the basic science side, the MRI and fMRI, some concerning stuff. We're seeing on the medical, like kind of population-based stuff, we're seeing some concerning stuff with psychosis and mental health stuff. We're seeing the neurocognitive, the drop in IQ. A couple studies have shown a drop in IQ. So when you add this all up, it really comes down to functionality. And there have been many studies that have shown that people that use marijuana regularly have more relationship problems, worse educational outcomes, lower career achievement, and reduced life satisfaction. So this is not just, finding some outcome on some study that really has no relevance to people's life. This is actually affecting how people live their lives when they use cannabis regularly.
Absolutely. It's a funny, I was giving a talk for a non-medical audience, and somebody raised their hand and they said kind of jokingly, well, my boyfriend in college told me that cannabis isn't addictive. And that is one of the myths that I always try to discuss, is that cannabis definitely does lead to addiction. And all the things that you just described, it's how we diagnose somebody as having a substance use disorder. How much does it actually impact their functioning? And so oftentimes, I don't have patients that are that I'm treating for cannabis use disorder. They may not have come to me for cannabis, but through our discussions and through us discussing the criteria, the DSM-5-TR criteria for a cannabis use disorder, how much is it impacting your relationships? Is it impacting your employment? Are you spending more time, than you had anticipated trying to get this? Have you tried to cut down and not been able to cut down, and so on? Those impacts on their functioning and their life, they will come back later and say, I probably do meet at least two of those criteria. That would be a mild use disorder over the last year. Let's talk about it. So certainly impacting lives. Sometimes in treatment settings, patients will be surprised when somebody is there in a group for cannabis when others are there for alcohol or opioids or stimulants, because there's, again, this misperception that it doesn't impact life, but it certainly does. And more I'm seeing patients in my clinic present or not present and later reveal that they have been very much affected by cannabis.
I would say the same thing. I see it in my clinic all the time. And anyone that thinks it's not addictive and not disruptive to people's lives is just really kidding themselves. And we have science to back that up. And, doctor, at the end of the day, I'm really not necessarily anti-cannabis. I may have feelings about it, but what I really am is pro-science. That's what I am. I'm pro-science, and I'm pro giving people accurate messaging so that they can make decisions that are based on facts, scientific facts, or likely facts, which sometimes is the best we can do in our business, unfortunately, versus myth and perception and marketing and mythology. So my question for you is, you've stood up and you've been a voice, and I've read some of your stuff on this, and I'm trying to do that. Why are so many of our colleagues, why do they shy away from talking about this with patients? Why do they shy away from standing up? I almost feel like some doctors are like they're afraid to go against the cultural trend, but it's like, we're scientists. We're supposed to go with the science. Whatever the world is saying, we're supposed to say the truth.
Mm-hmm. Yeah, if you think about another substance that has been on my list of policy and research areas is nicotine tobacco. If we think about 50 years ago, doctors were smoking with their patients. It was
recommended at times.
Exactly. Advertising included doctors. It was part of the normal times, and we know now, or we've known for many years at this point, that tobacco is still the leading preventable cause of death in this country and worldwide, really. So it's a matter of education. It's a matter of awareness. I think a lot of physicians, and it's really hard. I imagine I study addiction, and I work in the field of addiction, so I get all of my time dedicated to talk about mental health and substance use disorders. But for primary care physicians who are trying to, in a very crunched system, squeeze more into less time, it is hard on a topic like this that they might not know as much about, that to squeeze that in and have that conversation. And so it really starts with this awareness. Oftentimes when I'm giving talks to general clinical audiences, I talk about just include it in your screening question. If you ask somebody about if they use drugs, for example, they're not actually going to tell you that they're using cannabis, because for them, it's not a drug. They may have, be considering it as medicinal, but all the more reason for us to get the data on that and include that in our documentation, because there might be interactions with other medications. So there's an element of education, kind of the cultural acceptance, and also the limits of and the constraints of the healthcare system.
Exactly, but I do feel like there's just, like, I'll put it to you this way: if you stripped away all the jokes and all the movies and all the social and the cultural mythology around cannabis, and you just evaluated it strictly on the science, if Pfizer made a drug where there was this level of potential harms so long and potential benefit so short, what IRB in the world would approve that to give to patients? What doctor would recommend this drug X? If it was made by Merck or Pfizer, I submit none would. So there is still this social and cultural thing that I think is keeping us from really saying what the science is telling us.
I agree, and I think it'll just take more podcasts like this to help change that.
More time. And lastly, and then I'm going to let you escape. Do you have any idea? Do you talk to your patients about the medical effects of cannabis? Because that's one of the things that I've been really shocked by is some of the studies. The cardiovascular, strokes, heart attacks, heart failure, all-cause mortality. One paper in JAMA a few weeks ago showed almost double the rate of all-cause mortality in young under 50 cannabis users with no risk factors for heart disease versus non-cannabis users or people without cannabis use disorder. So, do you talk about the medical side of it at all with your patients?
I do. I usually don't lead with that, because similar to my patients who smoke cigarettes. They're less interested in that to begin with, but certainly increase in heart rate, blood pressure in the long term. Both American College of Cardiology and American Heart Association have found increased risk of MI and stroke, even when they control for tobacco use. Certainly lots of respiratory conditions, bronchitis, COPD, especially in older adults, all concerns. And then of course with older adults, the things like sedation and cognitive impairment, falls, and then finally for anybody, things like motor vehicle injuries that has gone up. We have really great insurance data that demonstrates that in states that have changed cannabis laws, there has been an increase in individuals who test positive after accidents. So those are all very practical, real world things that when I get the in with the patient, I will start talking about as part of my approach to motivational interviewing with them.
100%. And since you bring up the nicotine thing, I'll end it on this. Like we're repeating the public health mess that happened like a century ago and took us like half a century to fix with tobacco. We're repeating that with marijuana and cannabis. That's what's happening right now. And I think it's going to take a long time to fix it, but we have to get the public, illegal or legal, it doesn't matter. We have to get the public messaging right. Very well said. Anything else you want to add, producer Dave? You've been silent.
I've been listening and learning, and I'm gonna throw away all my joints that I have in my bag here. No, I don't actually. Excellent stuff, Doctor. Thanks so much for joining us. Now, do you want the doc to stick around for the remaining parts of the program?
I think the poor doctor wants to probably move on with her life.
Oh, okay.
That's the sense I'm getting here.
This was a lot of fun. Thank you so much for including me, and all the best with your podcast. I'm really excited about it.
Oh my God. Well, listen, thank you so much. It was a true pleasure to have you. We wish you the very, very best. If you make it out to Boston anytime soon, please hit me up. My wife and I would love to take you out to dinner somewhere and get to know you a little better, but wishing you the very best. And thank you for making the time to join us, and we'll continue to follow your career and, and the great work you're doing.
Great. Wonderful to chat again. All the best with the sports minutes later.
Yeah. We'll get to that later. We'll save that for later. We'll spare you of that. Have a great day, Dr. Das. Thank you so much. All right, producer Dave, that was a great interview with Dr. Das, but we are ready to move on to In the News. We have a lot of great stuff to talk about, things you may have seen on your news feed on social media, while scrolling the internet, on television. We're going to talk about some of the hottest and best stories in the world of healthcare and medicine right now.
In the News.
Okay.
There you go. I feel better. I feel a lot better now. I don't know about you.
It's not much, but it's something.
It's something, right? Absolutely. It's great. Okay. All right. So let's talk. This one was all over my news feed, and really still kind of is. From USA Today, long-term use of melatonin supplements may have negative effects on cardiovascular health. Did you see this study?
I did not, but that's scary because melatonin. I think people pop melatonin like Flintstones vitamins.
Well, right. So just to give a little background, I shouldn't use the word study because it was not released as a paper, and that's a red flag. This was data presented at a conference during Scientific Sessions, American Heart Association Scientific Sessions 2025. So I haven't seen a full publication yet, and it's the same thing that we talked about last episode, which is that how we correct for confounding and how the methodology we use is so important. So keep that in mind. But basically what they found was that long-term use of melatonin supplements, often used to promote sleep health and address insomnia, was associated with a 3.5 times higher risk of a heart failure diagnosis, higher rates of heart failure, hospitalization, and death from any cause. So pretty scary stuff because people pop melatonins, I think, like they're candy.
And they're over the counter.
They're over the counter.
Yeah. My son sometimes takes one to sleep. But so is there something you recommend as an alternative for your patients who have trouble sleeping?
Well, let's talk a little about this study first of all, because I had to put on the old epidemiologist cap, and I did that a little, and I think that's why it's dangerous. There is not a full publication, by the way, because I can't fully analyze it. But a couple things. Number one is, let's just say this: supplements are totally unregulated. People put anything into their body. People that won't get a vaccine, people that won't get a shot. People that won't take a studied medicine that their doctor prescribes them will go order some supplement on Amazon and just pound it like it's candy. When the reality is, we often don't know what the health effects of these things are.
Yeah. I'll tell a story, and it's embarrassing, but for the good of the show, I'll tell a story. I went to a GNC, natural foods, whatever. All those vitamins. I don't know.
I think they're gone.
This was
dating
years.
ourselves if we talk about GNC. Man.
Yeah, this was years ago. But I bought a supplement that was billed as an alternative to Viagra or Cialis, and I figured I'd try it. If I can buy it at the grocery store rather than get a prescription, I'll try it. Never mind whether it worked. That's not the point of the story. The point of the story is about an hour and a half later, I was at this cocktail reception and started feeling faint.
Right.
And I had to sit down. I told people it was a reaction to some medicine I was taking. I didn't mention what it kind of was. But my point is,
it affected you.
Yeah, heavily. It took 3 hours for me to just feel normal. And that was something like a lot of people, I think, figure you buy it at a vitamin store, how heavy can the effect be?
Yeah, and the truth is, these supplements are the wild west of medicine. Really, like there's nothing. When something's a medicine, it has to be studied, and it's under a rigorous process of study by the FDA. If something's classified as a supplement, there is like almost nothing they have to do. They can make almost any claim, and they don't have to do anything for either efficacy, which is effectiveness above placebo, the term efficacy, or safety. It's completely unmeasured.
There was an alternative to opioids called Kratom. I don't know if they still make it. You familiar with Kratom?
I've never heard of it.
Yeah. Again, you could buy it at a vitamin store, and I saw a segment on it, but I think it kind of gets you high, as an opioid would if you take enough of it. And I don't know if they ended up regulating it or not, but there's stuff out there, like you say, wild west.
It's very scary. So people should be really careful. But all that said, for this particular study, this particular data with melatonin, my skeptical antenna is up on this, and I'm going to tell you why. Because number one is there have been a lot of studies that have shown that actually melatonin has been investigated as a potential treatment for heart problems and may actually have cardiovascular benefits. So this study kind of goes against a lot of other studies, some of them well done and recent, by the way. So that's my first problem. My second problem is this is a totally observational population-based study. They did try to correct for 40 different things, but you never know if they missed something. So this data looks like it was really prone to confounding. So I think you'd have to really look at the methodology and see if you think it's credible, and then obviously do repeat studies. I would not push the panic button about melatonin based on this study quite just yet.
Okay, good to know, especially if you're taking it in small doses, right? I mean,
right, exactly.
Take one to get to sleep.
And the other thing I'll say is, like, look at the alternatives. I mean, first of all, people need to sleep, right? Mm-hmm. And then look at the alternatives. None of them are without risk and side effect. You even like these Ambiens, Ativans, Xanax, you look at the data on those have well-established risks even when used exactly as prescribed, including higher rates of morbidity, frankly, higher rates of dying, even if you take it exactly the way it's prescribed to you, just because of the nature of the medicine, what it does to you physiologically, there's some risk to that. So it's a small risk, but there's risk to it. So everything has risk to it. So talk about it with your doctor. That's the take home, but don't push the panic button. Okay, next story on In the News. All right. State's second largest health insurance company announces 250 layoffs. This is just following up on a study we did, a story we reported on a few weeks ago. Harvard Pilgrim Healthcare and Tufts Health Plan parent company cites rising medical and pharmaceutical costs for the reason of the cuts. They laid off 250 people for Tufts and Harvard. And the reason for that mainly is, do you know what?
Well, the budget's a mess. I don't know.
It's GLP-1s. It's Ozempic. It's Mounjaro.
Oh, okay.
These companies lost so much money on these drugs the last couple of years that they're having to really restructure the way they're operating.
So we talked about this before, but what do you think the future of Ozempic and similar drugs are like?
I mean, honestly, I really thought the president did a good thing with the plan to try and lower the cost to people, because these are great drugs. And the irony of these drugs is they will save the healthcare system a lot of money, but that might not be for 5, 10, 15, 20 years. Long-term. benefits from weight loss. And I can tell you for sure, health insurance companies, their main focus, unfortunately, is always on that year, if not that quarter, right? And so that's sort of the collision of the worlds, if you will, where like what's good for the system might be giving someone a medicine that may benefit them 5 or 10 years from now. But if Blue Cross is going to lose $300 million a year and go out of business or something in a couple of years, they have to stay in the game and survive, and they have to do what they have to do to survive. And that's where this sort of war of these sort of priorities comes into play, and why it is this is the part of our system that's kind of broken.
We will keep you updated.
100%.
I'm sure that'll keep coming up.
Okay, next study in the news. Childhood blood pressure predicts cardiovascular death in adulthood. I thought this was really interesting. Blood pressure matters at all ages. This is from Medical Life Sciences Journal. Children with higher blood pressure at age 7 may be at increased risk of dying of cardiovascular disease by their mid-50s, according to research presented at the American Heart Association Scientific Sessions 2025. So basically, take home here is that if you have high blood pressure, if your kid has high blood pressure, even at a really young age, okay, they're at high risk of having cardiovascular disease in midlife and dying from cardiovascular disease in midlife.
I take meds for high blood pressure, and I was diagnosed as a young person, but I seem to remember they were really hesitant to prescribe any drugs. Do drugs get prescribed for kids who have high blood pressure?
Yeah, that's a great question. I think so.
Yeah.
I'm not a pediatrician, but
Right.
I mean, things have changed a lot since the last time I worked on a pediatrics rotation, just in terms of like how these things are handled and how often they are, high cholesterol, high blood pressure in kids, I'm thinking of. But this is what I think people need to know is that the process of atherosclerosis, okay, it is a process of scarring of your artery from the inside out. Just like when you cut your arm and you get a scar on your arm to heal the cut. The same thing happens inside your arteries. So it doesn't matter whether you're 7, 70, or 107, right? If you have risk factors, things that damage your arteries from the inside out, you will begin the process of atherosclerosis and cardiovascular aging. I fully believe, Dave, that it's possible to be, for most people, to be more or less cardiovascular disease, atherosclerosis proof if they avoid risk factors, right? The other side of that coin is, at any point in life, and this is what this study shows us, at any point in life, if someone develops cardiovascular risk factors, they will begin the process of cardiovascular disease even if they're 7 years old.
Good to know. Good to keep an eye on. But it's kind of scary.
Very scary.
For kids, yeah.
Well, yeah, as a father of 4, it's like, physical activity, right? It's so important, feeding kids good food and keeping these kids healthy body weight is literally gonna affect their health for the rest of their life.
Absolutely.
All right, let's move on. Next one, JAMA Psychiatry, intranasal oxytocin and physical intimacy for dermatologic wound healing and neuroendocrine stress. This is a terrific paper. So basically, this was a randomized controlled trial, okay? A randomized trial that looked at 2 groups of people that had wounds. And in one group, they gave them intranasal oxytocin, which is a hormone that mitigates stress, okay, sort of a relaxation hormone, and then also measured their daily physical intimacy, which is thought to increase some of those hormones of relaxation, if you will, versus those that didn't do that. And they found that the people that were in the low stress group that got the hormone that had more physical intimacy, their skin wounds healed faster.
Wow, that's really like when the mom kisses your boo-boo to make it feel better.
Right, exactly. But it's mind-body medicine is really what it is. And when people think mind-body medicine is voodoo or magic, it's not. It's actually hormones, and it's real.
And so it never hurts to give somebody a hug.
Well, I think that's the real take-home here. But I think the take home here, though, honestly, is like when we look about how stress affects disease, right? And, and when, we just talked about how cardiovascular aging is a process of scarring in your arteries, right? And people that are constantly stressed and constantly tense, right? And how that might affect that process. So it just goes to show that a big part of being a healthy person is having healthy
relationships,
loving relationships,
and love
and intimacy.
Yeah.
Okay. Next one. Advice to feed babies peanuts early and has helped thousands of kids avoid allergies. So are you aware of this?
No.
Yes. So, obviously peanut allergy is like a cultural phenomenon in the last like 20 or 30 years.
Right.
So basically now doctors have started to tell mothers, give your children peanut butter, very young age, expose them to things at a very young age to prevent allergies. It turns out it's working. The rate of peanut allergies in children ages 0 to 3 fell by more than 27% after guidance for high-risk kids was first issued in 2015, and by more than 40% after the recommendation was expanded in 2017. So give your kids peanut butter.
Thank goodness.
Yeah.
I mean, I know I have occasionally visited my old summer camp, and one summer in recent years, they invite the alumni out, and we were in the mess hall, the cafeteria or whatever, and there was no peanut butter. It was almond butter or some other kind of alternative to peanut butter. What's your theory, or is there a prevailing theory on where the peanut allergies all came from? Because, when I grew up, there was never like, Jimmy's got a peanut allergy. He'll die if you throw him a Reese's Pieces,
Yeah, like it just kind of became a thing like around the late 90s, right?
And I don't know, I've heard the theory that years and years of all the stuff that Americans, that we put in our food, preservatives and everything, caused some kind of imbalance or something and caused these allergies. But they change people's lives, needless to say. But this is good news, I guess, and it kind of makes sense.
I wonder if it's all these like antiseptic, antibacterial cleaning products that have kind of proliferated in the last 30 years. Like a big part of how our immune system develops is immune sensitization and being exposed to things. Mm-hmm. That's like critical for how our immune system develops. So I think there is some literature that the antibiotic, antibacterial kind of revolution that kind of manifested in the 80s and 90s might have driven some of this. And I'll look more into this after this episode.
But we live in a world where for a while it seemed like everyone was carrying around antibacterial lotion and I don't know if you agree, but I was skeptical as to the general fervor with which a lot of parents try to prevent their kids from getting sick.
Right.
Not necessarily a great thing,
right.
But let them get a cold, let them get sick. Their immune system builds up.
It's unfortunately part of what happens on this rock. I mean, if you don't ever get sick, then when you do get sick, you get devastated. I've always said there's two things that if they cause disease, I'm absolutely screwed. One is hand sanitizer, and two is almond milk because I rip it like it's air. Okay, and hand sanitizer. I've been working in a hospital for 20 plus years now. So like I'm constantly washing my hands with hand sanitizer. If that stuff is somehow bad for you, I'm screwed. Like I use
it too. I keep it in the car because my theory is that there's no place to wash your hands in the car, and there's always germs about. But and
as for almond milk, like I drink like a couple glasses of that a day. Like I don't drink cow's milk, but could that be bad for you? It's possible.
I think you're fine.
I hope so. I really do. Because honestly, I'm screwed if almond milk's bad for you. Okay, last one. Flu season could be nasty this winter. This just came from NPR today. Basically, the U.S. may be entering another rough winter for flu, according to early data. The signs are it could be a big season, says Richard Wibby, who studies the flu at St. Jude's Research Hospital in Memphis. The flu season might have a little bit of a punch to it this year. So we're looking at another bad flu season this year. Last year was a really bad flu season. Really bad. That was probably the worst of my career.
This is just anecdotal, but I already heard two people I know that have had the flu the last couple weeks. And if you've never had the flu, now have you had the flu?
Oh, yeah. I had it last year.
Did you really?
It kicked my ass. I've had it many times, and it never hit me like that. Last year kicked my ass.
As far as I know, I've only had it once. I was in my 30s, and it was the worst pain, discomfort that I've ever had. And I've had shingles. I've had COVID, of course, a couple times. The flu is devastating.
Yeah.
It is rough.
Well, exactly. It's like hiding in plain sight, right? We also focus on all these other diseases, COVID, everything else. And first of all, last year, flu was worse than COVID. It killed more people, caused more disease. And there's a lot of reasons for that. We discussed it on an episode of the podcast last year. But, flu is just, it's like we just assume, it's like car accidents, right? We just take it as part of life.
Right.
And it's like, it's just one of those things. But it is so devastating. on a human level.
Do you recommend flu shots?
Of course, yeah. I mean, everyone should get a flu shot. I was trying to make this episode vaccine-free after last episode and some of the like disturbing comments we had on Facebook, but it's a part of medicine. It's unavoidable. So whatever, welcome to reality. But yes, people should get a flu shot. It's a good idea to get a flu shot unless you have some medical contraindication. Okay, and then we're going to do a little quick news segment, Dave, very brief. We are going to do reader fan mailbag. I just call it fan mail. So we got a question from one of our fans. Her name is Valerie Snell, and she's asking me about GLP receptor agonists, so-called Ozempic and Ozempic-like drugs, and do they affect blood pressure? And so a little deep dive on this. So obviously, if we lose weight, that's good for blood pressure. So the answer is yes, right? But actually now, there is actually literature and data. And I have one study in my hand that was in American Journal of Hypertension just last month. GLP-1 receptor agonists and blood pressure, basically independent of weight loss. Now we think that there is some benefit from just Ozempic on your blood pressure. So kind of interesting.
I'm going to ask my primary care person about that, because then it's like a double benefit. You get the weight loss and. Like I said, I have high blood pressure. It does scare me. I don't know if I told you, I had a little health scare. I had double vision, which for the spell of double vision for a couple hours, and I was worried. The docs were worried I had a stroke. They still don't know why. Like a lot of things, it will remain a mystery. It hasn't come back since, but I got more vigilant about my blood pressure meds because I thought, probably, So and it's like. You don't see it coming. So good news for people that use Ozempic, I guess.
100%. Now, the effects are modest. I mean, the effects in totality, like if Ozempic helps you lose weight, and I've seen this in so many of my patients, I mean, we take a lot of people off blood pressure meds after they've been on Ozempic for a few months because they start losing weight and the blood pressure goes down and they exercise more, they feel better, they eat better. So that happens. But independent of all that, it's a modest effect. They said average 2 to 5 millimeters of mercury systolic. So, even if you don't lose a freaking pound on Ozempic, it's going to benefit your blood pressure a little bit. So very interesting. Of course, the greatest benefits for Ozempic are for your heart. That's what I think. That's why I prescribe it to so many people. So recommend discussing with your doctor. All right, my friend, anything else you want to bring up? Anything you saw in the world of medicine that you want to run by the doc while I'm here?
No,
or can I go off the clock?
Let's go off the clock. You ready?
All right, non-medicine topic of the week.
Here we
Let's go. Best segment on the show.
The doc is off the clock, so it's time for the non-medical topic of the week.
All right. Well, it is Thanksgiving week, so for the non-medical topic of the week, what else? We're going to talk about the upcoming Thanksgiving holiday. And Thanksgiving is a very interesting holiday because it is a holiday of traditions. And some of those traditions invariably one might love, and some of them invariably one might hate. And what I want to ask you today, Dave, is what is the Thanksgiving tradition that you could do without?
Well, I hope I don't cause a big stir by proclaiming this, but mine's a particular side dish.
Okay, go for it. No, it's not mine.
Okay. Cranberry sauce. I'll die a happy man if I never have it again. I don't care if it's fresh. I don't care if it's in the can. It does nothing for me.
Really?
Yes, and there are it also wastes space on the plate because there are so many great sides available to humans. I love the mashed potatoes. I love when people have mac and cheese, candied yams, spinach casserole. All that's great. Cranberry sauce. Sorry.
I have two, and I'm going to bring up one of mine now because it segues in perfectly with yours.
Okay.
My Thanksgiving tradition I can do without is turkey.
Oh, see, I almost said
less.
that too.
But if I am going to eat turkey, it is really hard to cook a turkey.
Oh, yeah.
Most people cannot cook a turkey. And I've had some really dry-ass turkey on Thanksgiving. Like nasty-ass turkey. And if you don't have cranberry sauce, you might as well be eating your boot.
So you don't mind cranberry sauce as a tonic to, but I'm with you. It's turkey. When do we eat turkey during the year? Deli turkey. I mean, that's different. I think
different thing altogether.
But turkey, yeah, it's easy to screw up when you cook it. It takes forever to cook it. Yeah, why do we do it? I went to one year where they had steak instead of turkey, and it was such a great change of pace. Amazing.
Yeah, I mean, my family, we do turkey. You know, my aunts do like a huge feast, right? So they obviously do turkey, but they do fish, they do tenderloin, they do all kinds of other stuff, including a bunch of Arabic food too. And the last couple of years, I've just been like, why am I wasting valuable stomach space? I mean, on Thanksgiving, your stomach space is a valuable commodity.
You gotta have a plan.
Waste it on a nasty ass turkey. It tastes like, oh man, it's been out in the sun for 3 days. No thanks. No thanks.
Here.
All right. And now my other one, and I know
Okay.
this is going to resonate with you too,
Okay.
and it's kind of segues into the Boston Sports Minute. I am over Detroit and Dallas being on Thanksgiving. Stop. I don't care about these weenie ticket holders in Detroit that are stuck on this tradition. Their teams have been lousy. Detroit is good now, but I mean, look at the last. We got to get.
They're
some
almost
better
never
games.
both good. One of them is usually terrible. Right now, the Cowboys are somewhat entertaining at least, but they're terrible.
When was the last time we had 3 even decent games?
At
on
least they
Thanksgiving?
added a third game that doesn't involve the Cowboys and the Lions.
Right.
Yeah, well, why not plan ahead and make them? The whole country's watching, and there's no alternative to the game you're watching at the time. You can't click over to a different game. You're stuck with that game. So pick 3 marquee games. It's not that hard. I mean, think of all the great teams that are going to be home for Thanksgiving, and never even mind the Patriots, who we didn't know they were going to be this good.
So the games this year are the Packers at the Lions, which is absolutely
That's a good
game.
one.
That's a great game.
Yeah.
The Chiefs at Cowboys, that's watchable.
Yeah.
That's watchable.
Entertaining.
And then the Bengals at the Ravens, that's kind of a skunk.
Yeah, the Bengals are absolutely terrible, and the Ravens aren't much better. Although, yeah. So football's a great tradition on Thanksgiving, but yeah, I agree. Mix it up. I don't know what it's. This is one of those things that I feel like this is the way it's always been done.
If I'm going to have to like invariably watch some suck on Thanksgiving, I just want to be suck in a different uniform, different city, different look. Like I'm all set with Detroit and Dallas, and it's just I'm all set with it. I want to see something else. Throw me some Arizona. I mean, they suck, but at least it's different.
Yeah, for sure.
Something different, you know?
But I mean the Patriots play the Brady era. He played many times, but I
Yes.
can't remember if we typically played the Cowboys or the Lions or either one.
I know we played the Jets a couple times. And
Yeah.
I would say I hate it when the Patriots are on Thanksgiving. That sucks.
Yeah, because you got other things to do,
Other things to do.
and there are people talking when you're trying to watch the game.
100%.
Yeah.
And it's like, when you're watching these other games, you're kind of keeping an eye on the game, but you can't be totally immersed in it for the reason you
Right.
just illustrated. So
It's the same reason why when the Pats are in the Super Bowl, you want to avoid the huge Super Bowl parties where there are kids running around and people that aren't football fans making comments.
otherwise known as my house. Kids running around. I'll avoid my own house.
Don't they know not to bother Dad during the?
No. They know. They just don't care, Dave. All right. Well, this segues great into the next segment. Let's go to the Boston Sports Minute because we got so much to talk about there.
It's the Garden. It's Teddy Ballgame, Yaz and Poppy in Noma. It's Brady and Larry and number 4 Bobby Orr. It's Fenway Park. It's the Boston Sports Minute. Let's go.
Let's go.
Let's go.
Well, that was a great intro, by the way. I know
Thank
you
you.
used it a couple times.
Yeah.
All right. So, Dave, Boston Sports Minute. What do we got? I mean, the huge story is the Patriots right now and this like amazing 9-2 out of nowhere run they're on.
Yeah. As a fan, I'm trying to just remind myself to enjoy it because we had 4 or maybe 5 seasons of relative misery, and each of those seasons started with a little bit of hope. I felt like, when we drafted Mac Jones, he was supposed to be good.
Yeah.
We got, Gerard Mayo came in. They've been grooming him. That sounds good. Nothing was good about those things. But I was talking about you before we started recording today about how I almost am getting worried because it's too good.
Right.
Now, a lot of this is the result of historically light schedule.
Yeah.
They have, on the other hand, the good teams they've played them well.
They've played 3 teams over 500 in the last this whole run, and they've beaten all 3.
Right.
That's the Panthers. Don't forget the Panthers are 6-5. The Buccaneers and the
right.
Bills.
Yeah.
I mean, I think look, I love it. I'm just like, can it really happen that Drake May is really this good?
Yeah.
Like after what we just did with Brady, are we really going to go like 2 years or 3 years and then pluck another elite quarterback out of the draft? When you look at some of these franchises, Chicago, Arizona, the Jets. They've gone decades without a franchise quarterback. Are the Patriots really going to just pluck another franchise quarterback out of the sky and go on another 10-year run here?
Yeah, I'm terribly frightened he's going to get injured. Knock on wood, he won't. I hope he's not. It's not part of his background, anyways. Doesn't seem to get injured a lot. But as a fan, I'm again, try to enjoy the ride. Now, do you think that part of this euphoria is maybe a bit much, just because, Drake May, you got to grow up. He's still just kind of an adolescent, symbolically as a quarterback. He has to have some lumps. I guess last year he certainly had some lumps.
Yeah.
We lost a few games, and he's got a lot of literal lumps because he keeps getting sacked. I'm worried about that. But do you think he's got to? It's almost like it might behoove him to have a shootout or some kind of game that he actually loses and motivates him and he learns from.
Well, if you listen to I do a football podcast, as you know, if you listen to that at any point, one of the things I've talked about is like they've been able to win while protecting Drake May. They haven't had to have one of these games yet where they've lost control of the game and just said, Drake, go win this game. Go throw the ball 35, 40 times. All these games, he's throwing the ball like 25 times, 23 times, 27 times. He hasn't thrown for 300 yards yet. He hasn't thrown for 4 touchdowns yet. So you're right. They have protected him, and we haven't seen what it's going to look like when they fall behind by 2 or 3 scores and everything falls apart. And can he do it still then? Yeah.
I remember what I remember as Drew Bledsoe's coming out party.
Yeah.
Was a game against the Vikings.
I was there.
I was there as well.
Oh, man.
Yeah, it was, and every Patriots fan of this generation remembers that game because we were down, I think 20-0 at the half or something like that.
Yep.
And they said, let's just run the 2-minute offense for the rest of the game.
Right.
And Drew went bonkers, and it was so much fun. And he I felt like he got some confidence from that because look at what I can do when I'm needed to throw that many times.
Exactly. And as much as May has been elite at times and he's been great and it's looked great, like we haven't seen that kind of game from him yet. So I can't say he's the MVP. I love him. I think he's going to be terrific. I'm so excited.
He's a future MVP. That's what I want him to be. Let's not rush things.
Right. But I mean, he has to do it. He has to do it when it all falls apart for me to really say, okay, this guy is 100% for real.
Absolutely.
And then very quick, are you a Bruins guy, hockey?
Very mildly.
Mildly.
But go ahead. Give us the Bruins
They're
update.
doing great, right? Celtics are above 500. The Bruins are on a tear. They lost, they beat Montreal on Saturday. Then I think they lost Sunday night. But I mean, they're playing great too. So it's looking up right now for the whole Boston sports thing.
I heard a theory. It was Boston guy and podcaster Bill Simmons who said there might be something to other teams in the city lifting other teams, although it doesn't literally happen. But there's something to be said for when fans get enthused. I think they will support all the teams with a little bit more enthusiasm, which doesn't hurt.
Yeah.
And we had the reverse basically in the 90s with a couple of exceptions, but we didn't. Boston sports teams didn't win a championship in the 90s, and it was kind of like... It
was a rough decade.
People kind of giving up. And then once, it was almost like it felt like, not literally, but it felt like the Red Sox were playing off the Patriots, and those two franchises just turned everything around. And so let's hope the Bruins catch a little bit of that Patriots magic in a cosmic way.
I'm of the age where, like, I was too young to appreciate the Celtics dynasty. And when I started paying attention to sports, I caught like the tail end of Larry Bird,
right?
Who was like a shell of himself, back injury, Larry Bird. The championships were a few years in the past. The 90s were a rough decade. For
really
Boston
bad.
Sports. I mean, the Patriots teams were fun. They were fun. Pete Carroll and Drew Bledsoe and Bill Parcells. That was entertaining. It was fun. They didn't win a Super Bowl,
right?
And they had some rough years mixed in there too. The Red Sox were terrible in the 90s. It was a terrible decade for the Sox. The Bruins and Celtics also mostly bad. So I think if you're of my age, you really appreciate.
It's true.
What's happened here.
There were too many years where the guy on the poster was like Rick Fox or
Yeah.
Dino Raja.
Yeah, Dino Raja. Oh my
Raja
God.
was our franchise player. He was a good player, but
D. Brown,
he can't be
yeah.
your best player.
No,
Same
he
with D.
can't.
Brown.
Yeah,
Great role player.
They had some rough. Twan Walker, the
Antoine.
Walker wiggle. You know, I never seen a player hit more 3-pointers off the backboard. That was like his trademark. He'd fire these.
He called them all.
Yeah.
He called glass
Yeah,
when he
called
threw
glass.
it. No, he didn't.
He hit more 3-pointers and fired them off and hit the backboard and somehow ended up in the hoop. and Walker wiggle himself down the court. All right, man. Anything else you want to add before we wrap up this episode?
Terrific episode. Happy Thanksgiving to you, my friend.
Yeah, same to you, and happy Thanksgiving to all the audience out there. We're up to over, I think, 3,300 followers and 3,100 likes on our Facebook page, so we're getting some momentum here. Please follow us, subscribe, like us, and get our content as soon as it's released. Find us out there. Wishing all of you a wonderful, wonderful Thanksgiving, a wonderful holiday season, and we'll catch you next month with another episode.